So, welcome to the Northern New England Health Policy Internship Program. Uh, Today's session will be a presentation on the private health insurance industry in the United States. And my name is Marvin Malik. I'm one of the course director and one of the preceptors. And so, without further ado, let us begin. Uh, so. Um, As I said, we're going to look at the private health insurance industry in the US. And as you all may know, Cigna and United Healthcare, two of the bigger players in that industry. But we'll start off a little bit chronologically. One of the first private insurers in the US health insurance system was actually the workers' comp system. And that was developed in early in the first half of the 20th century, like around 1910, 1920, state by state, still regulated by states. It's about 1.2% of overall US health expenditures go to work-related injuries and illness. There's about 1,000 carriers, and uh, workers' comp funds uh, the cost of lost work days. Sometimes it'll pay off the cost of a long-term disability, like losing a finger at work when it gets chopped off or crushed. But the other thing it covers is simply the medical costs of taking care of injured workers. So that's about 1.2% of US health expenditures. The other very old system was motor vehicle injury related uh, uh, coverage. And one difference between that of covering the medical cost of motor vehicle crashes versus workers' comp is that in the workers' comp system, part of the agreement for the fact that employers were going to pay for work-related medical care, work-related injuries care, was that the workers were foregoing any right to sue the employer for the fact that they were injured, but in return, the employer paid for their care. With motor vehicle crashes, there could still be suing, but going on, but the your insurance policy could pay for your care. That often leads to retaliation, where the next year the insurer increases your charges for that insurance. So a lot of times, that care will either be paid for privately or it'll get submitted to insurance. So the coverage of motor vehicles is a little more less consistently related to that insurance. Whereas for workers' comp, it'll get usually be paid for in that manner, but through the workers' comp insurance. So let's go to the more conventional types of insurance. Fully insured health plan. And I'm not talking now about insurance you get through the workplace, either because you're the worker or you're a family member of the worker who's getting that insurance. So fully insured means that your employer uh, went to an insurance company and paid the insurance company for the coverage. So uh, there'll be a fixed premium based on the number of employees and the agreement. It'll be a different agreement between the insurer and each employer. There'll be a fixed premium each month based on number of employees and whatever that agreement was. And the insurer assumes financial risk for claims. So if that employer's work workforce required a whole lot of care, the insurer would lose money. They'd have to pay off more claims. And the insurer will pay for all covered medical services. So just to give an example of one that isn't covered, it may be that homeopathy or plastic surgery won't be covered as part of that agreement, but an appendectomy would be covered. So anyway, so the insurer pays for it all. And this is common among small and middle-sized employers that they'll just pay for a regular policy. Um, so the role of the insurer is to set the premium. And if it's an employer that has more than 50 employees, they can actually use underwriting, meaning analyzing the health of that group that who are employed at that workplace and set the premium based on how healthy they were or how sick they were the year before. But the insurer assumes full financial risks for all the claims once that agreement happens and they're paying the premiums. Um, and the insurer will administer the benefit, pay the doctors, those state insurance regulations that have to comply with. And usually there's a standardized insurance product that they'll offer to employers in the state. So the other type of situation is called self-insurance or self-funded. And in this situation, the employer pays the employee's medical claims directly. So if that employer, I'm sorry, if one of the employees of that company develops appendicitis and requires an appendectomy, the employer will pay for that appendectomy. And so in that situation, there actually might be an insurance company involved, but they're not assuming insurance risk. We'll get on that in just a second for a little more. Um, so it's kind of complicated for an employer who's paying employees medical claims directly to decide, well, how much do I actually pay for an appendectomy? What's reasonable? How much do I pay for a follow-up visit for high blood pressure? So all these different things. How about a mental health counseling visit? So the insurance companies would know all that. So even though the employer's going to pay for the appendectomy and the mental health visit or whatever it is, the employer will usually hire some sort of company, usually an insurance company, who's just administering the claims, but then the employer pays those claims. But the insurance company decides how much the employer should pay, and this was all agreed upon ahead of time that the employer agrees to use the insurance company's pay scale, and the insurance company had negotiated with all the doctors in the community who then had to say, yeah, that pay scale's all right. Or if they didn't like it, they wouldn't sign a contract with that insurer and that employer group. So this is all kind of complicated, but um, so the insurance company could serve as a third-party administrator to process all the claims for an employer. These are usually big employers. And just to reduce the risk, the employer can actually pay a really big insurance company for something called stop loss insurance for catastrophic claims. So let's say the employer is self-insuring, and let's say there's 1,200 employees for that insurer. Let's say one of them suddenly develops viral myocarditis and requires a heart transplant. So that may cost a whole lot of money. And so if it exceeds a certain threshold, then the stop loss insurer might pay some of that catastrophic claim. And anyway, so you may ask, why would employer want to self-insure? It sounds kind of risky. Well, this is usually done by large employers who have the belief, often with good reason, that their employees are healthier than the average employee that the insurance company is going to end up if they were to go with the fully insured model. So they think that their employees are going to be healthier and that their premiums will be lower. And you can see that for a very large employer, their health costs for a very large employee group with hundreds of thousands of employees may be predictable, and it may be lower than the average for what the average insurance company would offer for fully insured. So these very large employers who believe or have healthy employees, they can benefit from self-insurance. And most of them actually use that. So stop loss insurance I just mentioned, usually by very, very large, offered by very, very large insurers like Barclays. And it's used in self-insured employer arrangements generally. The employer will pay for this stop loss insurance. So, so how large insurers operate vis-a-vis self-insured plans, the insurance company will get an ASO, administrative services only, meaning they're not going to be assuming the insurance company's not going to be assuming the risk. But they give the insurance company a provider network, a pay scale, and they may even sell stop loss coverage. And often all that will be bundled into a single package. And the employer thinks that that's going to be cheaper than just being fully insured. Okay, so uh, and again, administrative services only we just discussed. So there are for self-insured plans, federal law uh, provides has some regulations related to self-insured health insurance plans. And this federal law, there's more than one law. ERISA is one of them. We'll talk about one other in a second. But this preempts state insurance regulation. So for all the self-insured companies who operate in a state, they don't have to follow the state's insurance regulations. They're exempt because they're self-insuring. So the federal law then, the ERISA law in this case, sets standards for plan administration, fiduciary duties like that they're required to have a lot of money so that in case they're having a bad year, they have the money on hand to pay. Requires reporting and disclosure of certain information to plan participants and allows employers to offer a uniform benefit package across the country in all the states in which they operate. So that's a lot easier administratively for the employer to have a uniform package across the country. You can imagine if like a Walmart or FedEx had to would offer a different plan in each state, it would be more complicated than just having the same plan across the country. So that's what they have. Um, so so far we've been mostly talking about employer-sponsored insurance, and in 2024, there were 282 million Americans who were working. That was the total. 265 million were working for firms that offer some health coverage to at least some employees. And so 99% of large firms offer coverage to at least some employees, but only 58% of small companies, small meaning less than 50 employees. Now, of those 265 million people, 217 million are offered coverage. So you can ask, who are the other 48 million who weren't offered coverage? They may be part-time employees, and that's usually what's going on. So 217 million Americans or their families were offered coverage. And of those, 155 million accepted the coverage. So you may ask, why did the other 62 million refuse the coverage? Well, it's possible that they're getting coverage to their spouse. It's possible that they can't afford the premiums because the employer is not paying 100% of the premiums. So if the employee has to pay 20 or 25%, they may not have enough money to do that. So they may refuse the coverage for that reason. Or they may feel that the coverage is terrible, it's got high deductibles, high copays. They may not want the coverage. Finally, maybe their wages are really, really low and they qualify for Medicaid, for which they don't have to pay 20% of premiums. So they may refuse the coverage for that reason too. So, out of the 340 or so million Americans, we're now down to 155 million who accept the coverage, and and that means the other 127 million people are working but don't have an employer-sponsored coverage. So that works out to about 56% of working Americans get coverage through the workplace, and add the families onto that. So this is how it breaks down. Of people who have a private health insurance in the United States, this was 2023, 60% of the people who had private health insurance coverage in the US were getting it through a self-insured employer. So again, that's usually a multi-state employer, UPS, some very large company, GE, or some large company that self-insures. 25% of people who had private health coverage had it through an employer that was fully insured, that was paying an insurance company to just cover it and take the risk. And then another 15% are getting coverage individually. And a little over half of those are getting coverage through the Obamacare exchange. And the other just under half were not using the exchange. They were getting coverage on their own. And again, the exchange offered subsidies, which have really dropped in value since this last year. The Trump administration got rid of the larger subsidies that had been initiated during the pandemic by President Biden. Anyway, so that's the breakdown. Most people who have private insurance are getting it through an employer. But now let's go to everybody in the whole country. And here you can see that all those privately insured people are the kind of the top half of this pie chart. The other three at the bottom are Medicare, which is about 19% of the population. Medicaid coverage covers 21% of the U.S. population, and about 8% of the U.S. population go uninsured. Okay, and by the way, some of those uninsured people were offered coverage at workplace, but usually they couldn't afford it. So that's sort of the overall model. Private health coverage covers 56% of the U.S. population. So let's talk about large group, fully insured plans. Here, a large employer decides they don't want to self-insure, and the insurer in this case sets the premium, and they're actually allowed to use prior claims experience of that employer. So if that employer's workforce was sick, the insurer might charge more. And they can also consider workforce demographic. If it's a very old workforce, then the insurer can charge more. So this is called experience rating, otherwise known as underwriting. And under Obamacare, otherwise known as the ACA, the claims history, in other words, how sick the workforce was in prior year, cannot be used to set insurance rates for small employers. However, they are allowed to adjust the rates if there's an older workforce, or if they're in a county where there's a lot of high health costs. There's high health costs in certain counties, or if the employees smoke. And then based on family size too. So this is called modified community rating, where they're not actually using the claims history, but there's all these proxies for claims history, like how old are they? Do they smoke? So all these things that allow the insurance company to better predict how expensive this work group is going to be. So inexperience rating, you're using prior claims to set rates. It's a form of underwriting. And under Obamacare, it's only allowed for employer groups with greater than 50 employees. Okay, so the cost of premiums, here we've got 2011, 16, and 21. And in that year, the total cost of private health insurance coverage for a family was 22,000. I believe that's now up to 26,000 or plus change or something like that in the most recent year. And you can see that the employees pay about roughly 20 to 25% of the overall premium throughout the period. And that there's been a lot of inflation over the last 15 years. Okay, so now we'll look at uh, workers. And in 2020, these two bars are 20 and 21, and they're pretty similar despite the pandemic. So on the left side are full-time year-round workers, and about 86% of them had uh, work coverage through their workplace, employer-sponsored insurance. Of these full-time year-round workers, about 9% were uninsured, and about between 6 and 8% qualified for Medicaid, basically public coverage. Now, for less than full-time year-round workers, that changes a lot. Only 66% of them are covered through the workplace. And uninsured now goes up to 16% of less than full-time workers are uninsured. And a much larger percentage of these non-full-time workers are now qualifying for Medicaid coverage. Now, occupational category is also a big factor. Professionals, nurses, lawyers, doctors, there are about 89, 90% of them will have employer-sponsored insurance coverage. And management, same thing, administrative support in production occupations and manufacturing. At the other extreme, so those groups will tend to have private coverage. On the other extreme are farming, fishing, forestry. Only 53% of that group had coverage through the workplace, even if they were full-time. And again, for mining and construction, it's pretty low. And service workers like, a place like Walmart or a gas station, they're less likely to have employer-sponsored coverage. So this is as you can see, it's kind of class-based. The poorer you are in the sort of lower class types of work, the less likely you are to have coverage. Now, people don't really feel that good about the coverage they get. 6 in 10 insured adults say they had a problem with their health insurance in the last year. And it's pretty much in all of them, uh, no available appointments for their doctor. That was the most common in the Medicaid group. On the other hand, the insurer paid less than expected. That was common in the employer-sponsored group. But insurance did not pay for care they received that they thought was covered. Care was denied. A doctor they wanted to see wasn't in the network or couldn't see them. Mental health wasn't available or not covered. They reached a limit on the number of visits. That happens a lot with mental health. Anyway, so there's a lot of complaints, regardless of what kind of insurance it is. And half of adults who had a problem with their insurance say that the problem actually wasn't resolved to their liking or not even resolved at all. Okay, so people have insurance, but having insurance is one thing, having good insurance is another thing. And you can see this is deductibles. Covered workers who have work-related coverage in the year this is the period extending from 2009 to 2021. And these lines, a line graph, and the lines are percentage of workers in that group who are paying a deductible of more than $2,000. What a deductible is, it means that for the first $2,000, you pay everything. You don't, regardless of what the service is, whether it's for an appendectomy or whether it's several office visits to get to $2,000, you pay all of it. Then when you hit $2,000, then your insurance will start paying something. And if you have a $50 copay for visits, then after you get to the $2,000, then you're going to pay $50 for subsequent visits, and your insurer will pay the rest. So whatever your co-insurance or co-pays are, you start paying only after you work through the deductible. And what you can see here is that the blue line are large firms. So only 22% of their employees in 2021 had a deductible of 2,000 or more. On the other hand, if you're in a small company, that percentage was 45%. So if you're an employee, a full-time employee of a large employer, there's a 45% chance that in 2021, you had a deductible greater than $2,000. And you can see where those lines are headed, so it's likely higher now. Okay, so you'll see this terminology. Preferred provider, these are types of insurance plans. In a preferred provider organization, you can go to any provider, and there is a network. Your insurance company created a network, but you don't have to go to people in that network. But if you do go to people who are not in the network, you'll pay a higher premium. And when you go to those other providers, you'll have higher copays. So just to get that kind of coverage, you pay more each month. And then if you actually go to the non-listed doctors, you pay more. So you pay more kind of twice. At the opposite extreme is an HMO that has a tight network. And if you try to stray from the doctors on their list, from their network, they may not pay at all. It's a good chance they won't. You can ask, but it doesn't mean it'll happen. Point of service kind of falls in between. They may pay for some specialists who aren't on the list. And then a high deductible plan, again, is no coverage till you work through your deductible. And later in the internship, we're going to talk about health savings accounts. Premium cost of various types of health insurance plan. Again, these all come down to around, in 2021, this all came out to around $22,000 a year. The interesting thing in this is that the fourth row are high deductible plans. And you would think that they would cost a lot less because if you have a deductible of $5,000, you would think the insurer wouldn't charge you as much for the insurance. But it turns out that they still may have very sick people on the plan, and that's where the costs really live. We're going to cover that a little bit later. Okay. So you should know what a surprise medical bill is. So in this situation, you have private insurance. Your insurance company has a network of doctors and hospitals they want you to go to. So let's say that suddenly you get really bad abdominal pain and you say, oh my God, this is really bad. I have to go to the hospital. So instead of rushing to the hospital or calling an ambulance, you go to your file cabinet and pull out your insurance company's list of covered providers and hospitals. And you look it up and okay, Memorial Hospital's on my list. So the ambulance then comes or you drive and you tell them, okay, please go to Memorial Hospital. It's pretty close and it's on the list. So you get to Memorial Hospital and they work on your abdominal pain and figure something or other out. And then after you get out of the hospital, you get bills. And the ones from the hospital for the hospital charges say, yeah, your insurance company paid most of this bill, but there's a co-payment, so you're going to pay that, or you didn't hit your deductibles, so you're going to pay it. But whatever, there's the insurer is recognizing it and is doing whatever, they're supposed to do, hopefully. However, then the next day another bill comes. This one's not from the hospital, it's from some doctor. And you think really hard and you say, yeah, that might have been the name of the ER doctor. And but this bill is being rejected by your insurance company, so you have to pay the whole thing. What happened there was that the insurance company approached the group of doctors who staffs that emergency department. They're not hospital employees in this case, but they have a private group. As this is especially common with private equity owned ER groups. Anyway, so there was a negotiation between that group of doctors that staff that ER and the insurance company, and the ER doctors wanted a whole lot of money. They wanted a higher pay scale than the insurance company wanted to pay. So there was no agreement. And you get a really big bill, and your insurer is not going to pay that bill. And you're pissed off because you say, I was supposed to go to that hospital, and I did go to that hospital, and it was supposed to be covered, but this is what's happening. So this was becoming more and more common, especially as corporate owners, private equity in particular, was refusing to make deals. And anyway, so this was becoming more and more common. So the Congress of the United States actually got its act together and intervened. So now there's a process. So if you get a surprise bill, you can go through an appeals process and it'll probably go well. And your insurance company may even tell you what the procedure might be for this kind of situation. Anyway, so this goes on in the US. By the way, most of everything we're talking about is unique to the United States, pretty much. None of the other developed countries have any of this lack of coverage or huge deductibles. None of this happens. Surprise bills. Anyway, so in general, people who have poor physical health are more likely to rate their insurers negatively. And regardless of what kind of insurance they have. And I think this is actually an important group because if you ask people who never were sick in an entire year how they feel about their health insurance company, the insurance company might have said, oh, please go get your vaccine, and you say, well, they should say that, so I guess it's a good insurance company. But if that was your only interaction with your insurance, you don't even know how good the insurance company is, but the people who didn't use their insurance always skew the favorability ratings of insurance companies because they tend to say positive things. So what the people who are actually in poor health, what they have to say is actually a lot more important because you kind of want to do how insurance, you want to know how insurance companies is going to respond when somebody actually needs your help. You're paying your premiums every month. That year you got sick, and so, your feedback it should be taken seriously. Okay, so especially now that the Trump administration has uh, taken actions that's going to make a whole lot of people lose coverage. For example, a lot of people are going to lose coverage through Medicaid, and a lot of people are going to not be able to afford the Obamacare exchange plans because the enhanced subsidies are going away. So Obamacare is about to get a lot more expensive, both high premiums and worse coverage, higher deductibles and copays. So people are going to be really tempted to look for cheaper insurance, and they will be able to find it, especially in short-term health plans. So short-term health plans were originally formulated to cover you when you're in unemployment, when you leave one employer and you're finding a job with another employer, but there's a gap. And in that gap, you've lost coverage from the first employer, but you don't yet have coverage through a new employer. So this was the theory that people needed short-term coverage, and say at 3 months, you hopefully be able to get another job in that time. And usually they let you extend it another 3 months if you didn't do well with your job search or something like that. So you were able to renew the plan. This slide was created before Trump 2.0. So here's how it worked. 3 million Americans actually were enrolled in these. Uh, and the American Cancer Society kind of got a little involved because they had patients. So here's an example: was a woman with breast cancer. Out-of-pocket cost on the exchange plan that the patient had been on was $8,000 a year, which is already pretty high. But then the patient got on a short-term plan and paid $50,000 in one single year. And then there were some patients with breast cancer. Most of them were diagnosed prior to their period on the short-term plans, and they paid 100% of the cost because short-term plans are exempt from the pre-existing condition clause, even under Obamacare, and no one else has done anything to change that. So, um, Biden made it so that you could only have short-term plans for only 4 months. And the reason why was because a whole lot of the people who were actually trying to use the coverage were not doing very well. But early in Trump 2.0, this really changed. And this is on the right is Mehmet Oz, who's the director of Health and Human Services. And he was saying, well, people need to have more options, partly because of what he himself had done to cut coverage on Medicaid and in the ACA. So now they're saying that these short-term plans uh, can run for 12 months, not just 3 or 4, and they can be renewed twice. So you can end up on these plans for 3 years. And the plans could do anything they wanted to with a pre-existing condition clause. If you had cancer, they could just say, we're not going to cover it, and that's what they do. And they could cap your coverage. So, like, for example, if you have cancer, chances are that your chemotherapy drugs, one drug, is likely to cost more than $100,000 a year. And if there's 2 or 3, you can do the math. And then there's all the doctor visits. And then there's the MRI imaging that you might need, or CT scans. And then there's x-rays. There's a lot going on. A lot of people need lots and lots of lab tests when they're getting chemotherapy. So they could just say, okay, you hit our cap. We pay $100,000 in a year. We're done paying. So lots of luck. And there's no cap at all on the patient's out-of-pocket spending. So the patient could just keep getting more and more bills and be responsible for them. So none of the Obamacare essential benefit package that required coverage for vaccines and preventable care and medications and mental health, none of that applied. They could exclude anything they want to. The only positive is that the plans are not exempt from state insurance regulation. The states can regulate these, and approximately 12 states do, most conspicuously California and New York. But the other 38 states really aren't doing very much to regulate these plans. They kind of let them do what they want. So we may be seeing more of this assuming this kind of policy is maintained. And then there's another source of private health coverage, which is GoFundMe sites. And it's estimated in 2019 there were 250,000 of these. And I read somewhere recently, I don't have data, but that this has actually been increasing. So it's about a third of all the GoFundMe accounts have to do with healthcare, unaffordability of healthcare. Okay, so if you look at bankruptcy related to medical costs, and what the patient's coverage was at the time of illness onset. So let's say you're diagnosed with lymphoma or multiple sclerosis or some illness. What was your coverage at the time you were diagnosed? So this is a retrospective study of people who went bankrupt from medical costs. What was their coverage at the beginning? And what you can see is that 60% of them started out with private coverage. And it just didn't do the trick. Either they lost the coverage because they were too sick to work and their employer cut them off, or they the deductibles and co-pays were just very high. Maybe they couldn't afford the premium. So it could have been a lot of things, but 60% of people who ultimately go medically bankrupt for medical reasons start out with private insurance coverage. So when you use your private health insurance coverage, you and the employer pay the premium. You show your insurance card when you go to the doctor. And the insurance company may have negotiated a lower fee than the doctor would like to charge, and does charge other people. And that's called a contractual allowance. The insurance company brings a large volume of patients to that hospital or that doctor, and they get paid a little less per visit. And if you're uninsured, however, you pay the whole fee. You don't have a contractual allowance. Now, you pay 100% of whatever that bill is until you hit your deductible amount. Say it's $2,000. Beyond that amount, you can pay a copay or co-insurance. Often the insurance company will charge you less for a primary care visit, but more for an ER visit or a specialty visit. And they don't, a lot of times ER, or if you dare to go out of network, you'll pay a whole lot more. And then for the pharmacy benefit, often there'll be tiers that you'll get a better deal if the drug is in tier one, but you're going to pay a higher percentage if the drug is in a higher tier that's probably costing the drug company more, and they couldn't negotiate. They failed to negotiate a better deal with the drug company, so you're going to get penalized for your doctor prescribing that drug. Anyway, so you get mail both from the insurer and the provider summarizing all of this, and eventually pay your bill. So let me just go on. So insurance company try to reduce their outflow of money, their costs, and they basically have four strategies to accomplish that. The first is to get you to pay more of it. And the more you pay, the less they pay. So that would help them. And in addition, if you know you have a big deductible, you may just not go to the doctor at all. So in that situation, the insurance company really benefits, because they don't even have to pay part of it. So that's a win for them. The second thing they can do is create a narrow network that only includes cheaper providers that they can pay less to. So that's another strategy, to cut down the number of available doctors and make deals with them that are better deals for the insurance company. So, for example, they may not get a deal with Memorial Sloan Kettering or other cancer centers. They may just say, go to your own hospital. You can find a doctor there who can treat your cancer. So that kind of thing often will happen. They can also have inconvenient providers. So, for example, I was in a Medicaid, I was a doctor in a Medicaid managed care situation, and they did not cover care at the hospital that was the closest for the population I was treating. And a lot of times the ambulance would just take them to the closest hospital and it wouldn't get covered. So the insurer would not pay anything to those hospitals. And then they can create what looks like a good network, but actually the people listed on the network either never signed up or don't even exist. And that's called a ghost network. When you look at the number of, say, mental health providers on the list, and it looks like there's 23, but when you start calling on the phone, the first five aren't taking patients or never even signed up with that insurer. So it's called a ghost network. Another strategy is to delay payment or deny payment altogether. And there's two varieties. One is to deny payment for care that's already occurred. So I worked as a hospitalist, and sometimes we would admit a patient and treat them. I once took care of a patient with viral encephalitis caused by herpes zoster, and the hospital and the insurance company, which was United Healthcare, refused to pay the bill. And it, it we had to go through a whole appeal, getting a lawyer. It was ridiculous. Anyway, so that's a payment denial for what they're calling unnecessary care, which is ridiculous. Anyway, the other variety, which happens more in office-based care or primary care, is denying payment for care that has not yet occurred. So that's called prior authorization, when they won't pay for a test that's contemplated but not yet done. So let's say that a patient comes in with severe pain, back pain. They have pain radiating down the leg into the little toe in their foot. Um, and they go to physical therapy for 6 weeks and there's really no improvement. And they might even have urinary and bowel symptoms. So this is getting kind of bad. So you say, okay, we've kind of waited. You went to physical therapy. We're going to have to do an imaging procedure to just define, your anatomical pathology. And so you try to order an MRI and the insurance company just won't pay for it, or they require a prior authorization. We'll get to that in just a second. And finally, the most effective strategy is just to avoid people who they have reason to believe will be sick. And we'll get to that more in a little while. Okay, so here's how prior authorization works. Let's say the primary care doctor orders that MRI I just mentioned. The MRI facility knows that no insurance company is going to pay them without going through this procedure. So they won't even let the patient into the facility until the primary care practice has dealt with the insurance company and dealt with the possible prior authorization. And so it's possible that it won't be required, but more likely it will be required. If it's not required, then the test gets done and it's green. On the other hand, if the prior authorization is required, there's two possibilities, which I actually didn't both include here. One possibility is that you won't bother dealing with the prior authorization for whatever reason. The patient just said, oh, don't bother. I won't even get it done. I'm disgusted. So in that case, the test doesn't get done. Or it's possible that the patient will say, yeah, please fill in the prior authorization. That's really the usual thing. Administrative staff and providers go through all this paperwork, complete the forms, goes to the insurer, and the insurer might approve it, in which case the test gets done. Or the insurer might deny it, and if the insurer denies it, you might talk it over with the patient and say, they said no, we could try to appeal. And so the patient might write a letter, you might try to talk to some human being, in the cubicle in the Dallas suburb where your insurance company has all their administrative employees or whatever. Anyway, so you can try to appeal it, and if the denial is reversed, then the test gets done. And if you fail on appeal, then the test still may not get done. You can also, if that doesn't work, you can go to the government and really try to fight it more to a state with whistleblower situation, or a state ombudsman rather is what I meant. So you can see how administratively complex this all is. So that is the way it is. This is extremely common. Just the Medicare Advantage population, which is 30 million people, there were something like 55 or 60 million prior authorizations required last year, and it's not good data on the private insurance market because it's so balkanized, but it's undoubtedly a lot more since there's, a whole lot more people with private insurance. So overall administrative costs, as you would guess, are far higher in the United States, and that on the left compared to Canada. This study's been repeated over and over again. It's always the same, about 4 times higher. A lot of money. And so there's something called the medical loss ratio, which for-profit publicly traded insurance companies report to their stockholders. And the medical loss ratio is a key metric for how well a private insurance company is doing. So, in the medical loss ratio is basically total medical costs they had to pay out over all the costs, including what they pay their CEO, what they pay, um, the administrators, the administrative employees. Um, Total costs also can be a proxy for their revenue. So, of the revenue they received, how much goes out to pay for medical care? And the insurance company wants that ratio to be as low as possible. In other words, if they get $1 billion of revenue, they just as soon keep all of it, or at least keep 950 million, or uh, at least pay out as little as possible. So the Obamacare legislation said that the medical loss ratio for large employer groups had to be had to be greater than 85%. So of all the money going to insurance companies to pay for care of large employer groups, more than 85% of it had to be going to medical care for those employees. And for small employer groups, they allowed it to be only 80%. And so and one of the thinking behind this was that they shouldn't be denying so much care, spending all the money in denying care. They should be, the Obama people said they should be paying money on medical care, not on all this administrative stuff, including denying care. So they wanted the medical loss ratio to be high and that they would be spending more money on health care. But for the insurance company, every penny they spend on medical care is, a loss to them. Anyway, so you can imagine it takes a lot of employees to deal with this. So between 1970 and 2014, the number of physicians in practice increased greatly from around 350,000 up to around 900,000 active and about 1 million total. So that's the green bars, the increase in the number of physicians during that 35-year or 35-year period. 45? Yeah, 45-year period. Anyway, and the brown is the growth in the number of administrators. And you can see it's just far, far outpacing the growth in the number of physicians. And that growth was especially prominent during the 1990s, which was the big era of managed care. Okay, so the states can also regulate insurance companies, and to varying extents they do. Is the plan solvent? Do they have enough money so that if they have a bad year, they'll have money to pay claims? Is it providing the promised benefits, or is it just denying all kinds of care? They also license insurance brokers who sort of sell health insurance policies. Some states mandate benefits. So, for example, in New York, I think women of reproductive age have to be offered a pap smear in their plan without paying extra. Anyway, and a lot of states ban the pre-existing condition clause and limit it, including for short-term plans, for the limited number of states that actually regulate short-term plans. They can require community rating. That's more problematic because insurance companies may just not offer the plan if they're not going to be allowed to do experience rating. They can require policy renewal for somebody who's already signed up in their plan. And then there has to be some process for resolving complaints. Okay, and then there's federal health insurance regulation. And one of them is called COBRA. And the main part of that is that if you leave an employer for any reason, you are allowed, for 18 months, you are allowed to buy into that insurance coverage. Your employer is no longer going to pay, but the employer may get a better deal than you're going to get on the individual market or on the exchange, the way things are going on the exchange. So you can pay the amount of money your employer's paying and keep your policy for 18 months. And that's under the COBRA law. And then there's HIPAA, which is regulates pre-existing condition clause, has limits on underwriting, renewability. There's a whole lot of confidentiality regulations under HIPAA. ADA requirements for disabled people, and then mental health parity. So there's a lot to that law, and there's kind of a complicated interaction with state regulation. And the ERISA law, we already talked about, that's the one that applies to insured companies, which, as I said, are exempt from state-based regulation. Okay, so if you don't remember any other graph during this entire internship, this is the one you need to remember. And what's going on here is that when you look around the room, for example, if you see a bunch of other people your age, so let's just talk about people between 20 and 35, or people over 65, or any other group, infants. For any group, if you look at the 10% that are the least expensive, a lot of times their costs, that's group number one on this graph, their costs often will be nothing or very little. So, for example, in an average year, 20% of Medicare recipients required no care. So this is even people mostly over 65. At the other extreme, the two most expensive deciles, the 20% of people who are the most expensive, these are people who fell off the roof or got cancer, some bad illness, lupus, something's going on. And these people take over 80% of healthcare costs, and often more than that, depending on the group. So for younger people, that even tends to be very high. For infants, the kids who require neonatal intensive care, they're going to be pretty high, whereas the average kid won't be. So anyway, this graph is of essential importance because the 6 or 7 groups on the left, those people cost almost nothing. So if the insurance company can come up with a population with those people, they're in really good shape and they're not going to have much cost. So the question is there a way for them to enroll all of those people and not get any of the people on the right? And that's the big quest. That's more important than any of the other maneuvers that insurance companies make. And this is their sort of big effort. And so here's some ways. Market segmentation is one strategy they use. Large groups in general tend to have lower average cost. Small groups a little worse, and then individual coverage is usually a really bad deal for insurance companies because if you're not working and you're an individual and you're talking about insurance policies which cost a lot, you're a whole lot more likely to buy that policy if you know you're in one of those two expensive groups on the right. You're going to pay. Whereas somebody who's really healthy and they're looking at a multi-thousand-dollar policy that for money they just don't have, they're going to say, well, I'll just go bare this year and hope things go okay without coverage. So individual coverage tends to have adverse selection where the sickest people want to buy it. And so the insurance company, is going to kind of avoid that market or try to have a pre-existing condition clause or just avoid the group altogether in one way or another. And then you can refuse to issue for a sick person. You can look at their medical record and just say, I'm not going to write the policy. And that can depend on age or occupation or health. If it's a situation where you're allowed to use a pre-existing condition clause, you can use that. Anyway, you can limit the enrollment period so that you kind of control who's going to enroll better and focus on that period. And you can cancel policies, and then rescission is when you have a policy, you're paying for it, And usually because you've gotten sick, the insurance company just says, goodbye. We don't want your money. We don't want to insure you. You're gone. Anyway, and that there's now most states regulate that out of existence. Obamacare didn't allow it either, but whether short-term plans will be allowed to get away with that, I'm not sure. But anyway, that used to happen a lot in the past before Obamacare. Um, so, and you can sort of figure out who you're going to try to not insure. So it happened in Vermont 25 years ago. And then this is actually one of the most notorious events in the history of private insurance that nobody knows about. But here, Aetna reported a tenfold jump in profits in the second quarter, 2002, as it struggled to recover from a money-losing spiral, began to show signs of success. The company earned 108.2 million or 70 cents a share in that year, compared to 10.6 million, 10 times less, 7 cents a share a year earlier. Revenue fell to 5.06 billion from 6.5 billion. Okay, so let's look at that. Their earnings went up tenfold at the very time that their revenue dropped. Now, if you were selling radios or computers or services, or regardless of what you're doing, you would not expect your earnings to go up when your revenue is falling. So this should like activate your antennae. This is interesting and weird. So Aetna shed unprofitable business. It was Aetna's first profitable quarter after a string of losses and a second consecutive one with gains. So the turnaround is on track. Aetna has stanched its losses by trimming expenses, raising prices, and turning away unprofitable business, cutting the number of people and insurers from 22 million people in 1998. Now by that year, 2002, they're already down to 14.4 million and expecting to be down to 13.7 million by the end of the year. Okay, so Abramowitz and the Carlyle Group said, oh, Aetna is clearly on a methodical road to improvement. Aetna hoped to begin growing again next year, but its ambition is not to regain its title as the biggest insurer. We were always the example because we were the largest. We're not interested in being the largest anymore. We're just interested in being the best and most profitable. The best. So that got them a lot of money. But just to go back to that, um, this was a big event because if they're dropping the number of people they insure by 8 million from 22 to 14, the question is, are the other insurance companies going to be running to pick up the businesses that they dropped? A lot of them probably smaller businesses or just businesses that had sicker employee groups, workforces that just required more costs. So this is not a formula to getting high quality coverage for our population, even though it's served Aetna very well. So I think competition among health insurers is a market failure. We'll talk later about why bad coverage tends to win out over good coverage. And I don't think that health insurance companies have really any useful efficiencies to offer. What can they do better? If their computer system pays claims more quickly and efficiently, they actually lose money. And then the doctors who have to contend with all these insurance companies face more administrative costs, and they then have to recoup the costs by raising prices because they have to hire all the extra administrative staff. And as we just talked about, cherry picking, trying to insure the healthy people and dropping the people who are sicker are the biggest strategies that lead to success in the health insurance industry. And these are all numbers, and so it's hard to imagine what this means to a real life human, but um, companies have to develop policies about what to do with sick employees who go on disability. And what you can find in this pie chart here is that about half the companies either when one of their employees gets very sick and say gets cancer or multiple sclerosis or some illness that's going to lead to a period of disability, a quarter of the companies, 27%, just fire the worker as soon as they go on long-term disability. And then a quarter of employers have a set number of months, often 3 to 6 months. And so about half the employers in the country sort of don't consider people who are on long-term disability to be their employees anymore, even if they can't find another job. So this little headline there, more bad news during chemo. This is a human being, who now thought she had a job, but she's diagnosed with, say, leukemia or lymphoma or something, some bad illness. And now she has not just the tragedy of having lymphoma, that could happen to people in any country, Canada or Britain or anywhere else, to have that kind of uh, event in your life, a tragic event. But it's only in the United States that the tragedy becomes a double tragedy that she's now lost her health coverage, and a triple tragedy that now she doesn't have a job to go back to if she gets better. So, yeah, this is one of the implications of this kind of system based on private insurance. And I just want to say that if you look at what insurance companies do, and one of the reasons I tend to argue that they don't really have much to offer in terms of um, what they can do to make the healthcare system more efficient. They pay medical costs. They spend a lot of time avoiding paying medical costs with dealing with prior authorization, utilization management, figuring out what to deny, what to put in their benefit package. They have to spend a lot of time on customer relations with complaints. And then they constantly having to deal with provider relations and trying to decide which providers to include in their network and which ones not to include if they're getting expensive or whatever. There's actually quality metrics, which we'll talk more about later in the internship. And then marketing and advertising. Again, this is a cost that would be unique to the United States. Lobbying, also unique to the United States compared to most other countries, developed countries. And then they're paying much more to their CEO and their administrative suite than in most other countries. And then if it's a for-profit company sold on publicly traded on Wall Street, then they also have to come up with money for profit for their investors. Um, and then they may have a paid board of directors. Most of the big companies do. And then there's investor relations. I think I spelled that wrong. They have to spend money to send reports to investors and to get dividends to the investors. And then there's fees related to public trading. So there's a lot of extra fees for-profit insurance companies. But all these costs are more or less unique to the United States or much larger here in the US. Okay, so that's it for the main part of your talk. And let me just share a little more. Um, I have some slideshows from a fellow named Eric Bricker. We'll see if we can get him to talk.
Hello, this is Dr. Eric Bricker, and thank you for watching A Healthcare Z. And today's topic is health insurance company subsidiaries. So, the major health insurance companies in America have a lot of subsidiaries, and those subsidiaries are confusing and they have all sorts of different names, so it's not obvious what companies are actually subsidiaries of the major health insurance companies. So, we're going to go through some of them today. It is so complicated. We have an A Healthcare Z first. It requires more than one whiteboard. So this is just part one. And in the second half of the video, we will have part two. Okay, first of all, we're going to start off with United Health Group. Okay, now United Health Group has the subsidiary of United Healthcare Insurance, or UHC. And then there's a subsidiary of United Healthcare Insurance, which is UMR, which is just the TPA underneath UHC for self-funded employers that need to do more flexibility than your traditional UHC, what are called ASO, administrative services only. Okay, next up, we have Optum. Of course, everybody's heard about Optum, right? Like the revenue from Optum is almost equal to the revenue of UHC itself. Okay, then Optum, look at this, it has a ton of subsidiaries. Okay, so one is Optum RX. That's the PBM within Optum. And then even Optum RX has a subsidiary within that, which is called MSR. And MSR is a group purchasing organization, a GPO that's actually headquartered in Europe that is used as a mechanism for collecting payments from the pharmaceutical companies. I have a whole other video about that. I will leave a link to it in the show notes. Okay, next up, then there is the Optum Specialty Pharmacy. That's right, because if you get your specialty medications through Optum RX, you can't just go fill that at your local pharmacy. You have to get a mail order through the Optum Specialty Pharmacy. Okay, next up is Change Healthcare. Of course, many of you are familiar with Change Healthcare because they had that large ransomware problem earlier in 2024. Now, Change Healthcare acts as the electronic interface for billing and then record of payment between the multiple health insurance carriers and thousands of doctors and hospitals across America. It's essentially the piping that allows those electronic transactions of billing and payment to occur. Okay, so they're the pipes. Change Healthcare itself has a subsidiary. It's called Interqual. Interqual actually creates the quote unquote standards for the number of bed days that are allowed for various diagnoses. So if you have pneumonia, they'll give you 3 days in the hospital. If you have acute renal failure, they might give you 4 days in the hospital, and on and on and on. Okay, all those quote unquote standard guidelines are created by Interqual, which is a subsidiary of Change Healthcare, which is a subsidiary of Optum, which is a subsidiary of United Health Group. Whoa, look at that. It's 4 layers deep. Okay, next up, we have the Advisory Board Company. The Advisory Board Company is actually a consulting firm that consults 4 large hospital systems to show them how to get paid more. That's right. United Health Group owns a consulting firm that tells hospitals how to make more money from United Healthcare itself, along with other health insurance companies. Next up, United Health Group actually owns large physician practices. One of the ones that it owns down in Houston is called Kelsey-Seybold. Now, Kelsey-Seybold is actually sort of like a mini Kaiser in that it's capitated. It gets a fixed amount of capitated payment per patient, and then it provides outpatient care, ambulatory surgery care. It provides imaging. It does lab. It's got OBGYN services. It's got home infusions. It does all sorts of stuff, but they don't actually run hospitals. Then there's WellMed, which is, again, is a group of physicians in Texas and Florida and some other places as well. And again, it's capitated, similar to Kelsey-Seybold. They take care of Medicare Advantage patients. And then there's Atrius, which is up in Massachusetts, and they're kind of your historical, it's kind of fee-for-service physician group, and they own physician groups in California as well. Okay, now, before I move on, what I've done is I've put these up and down arrows in circles. What are these up and down arrows? So, how do each of these subsidiaries make money? Do they make money by increasing healthcare costs to the government employers and patients, right? Those are the three folks that pay for things, right? It's the government, either federal or state, it's employers, and then patients out of pocket cost themselves. So it's those three. So do these companies make more money by increasing healthcare costs, or do they make more money by decreasing healthcare costs? Because all you need to do is listen to a quarterly earnings call for United Health Group, and they explicitly tell their investors like how they're going to maximize revenue and how they're going to maximize earnings and how they're going to maximize shareholder value. That's the whole point of the conference call. So let's see how each one of these different subsidiaries of United Health Group, let's see how they make money. Okay, United Healthcare makes money by making healthcare costs go down. UMR makes money by making healthcare costs go down. Okay, OptumRx makes money by healthcare costs going up. MSR makes money by healthcare costs going up. Optum Specialty Pharmacy makes money by healthcare costs going up. Change Healthcare makes money by healthcare costs going up. They want more claims and they want to charge their hospital and doctor customers more money for processing those claims. So they want to add cost to the system in order to make more money for Change Healthcare. Okay, next, Interqual actually makes money by healthcare costs going down. So interestingly, a subsidiary of Change Healthcare that actually wants healthcare costs to go up, Intercall actually wants healthcare costs to go down. Okay, the advisory board company, they make money by having healthcare costs go up. Now, even within their physician groups, it varies. Kelsey-Seybold makes more money if healthcare costs go down. WellMed makes more money if healthcare costs go down. But Atrius, because they're traditional fee-for-service, they make more money if healthcare costs go up. So United Health Group makes money with a sort of mix and up and down arrows. All right, let's move on to the Cigna Group. The Cigna Group has Cigna Healthcare, which is the health insurance arm, which is analogous to United Healthcare, and then it has a TPA subsidiary that's called Allegiance, which is analogous to UMR. That's for self-funded groups that want more of that flexible TPA. Okay, next up, then there's Evernorth, which is the other main subsidiary of the Cigna Group. It's analogous to Optum. And Evernorth, the vast majority of Evernorth is actually Express Scripts, which is the very large PBM that is sometimes abbreviated ESI. And then ESI also has a subsidiary called Ascent Health Services, which again is headquartered in Europe and is just like MSR. It's used as a mechanism for collecting payments from pharmaceutical companies for the PBM. Okay, next up, then you have Evernorth also has a subsidiary called Evercore, and Evercore is one of the two largest prior authorization companies in America. So they do a lot of the prior authorizations for United. United's outsourced much of their prior authorizations to Evercore, which is a subsidiary of their competitor, Cigna. So all these orthopedists and surgeons and all these other doctors that are trying to get prior cardiologists that are kind of trying to get prior authorization for services, they're actually using Evercore, which is actually a subsidiary of Evernorth, which is actually a subsidiary of the Cigna Group. So it's 3 layers deep. Okay, next up, Evernorth also has MD Live, which is a large telemedicine company. Next, you have Evernorth made a multi-billion-dollar investment in VillageMD, which is co-owned by Walgreens. And of course, there's like these VillageMDs that are in Walgreens pharmacies, and they're shutting a whole bunch of them down, and it's not working out. But they also own huge physician practices. It owns a huge physician practice in the Northeast called Summit Health, which is a bunch of like orthopedic surgeons and other specialists as well. So again, let's go through the up and down arrows for all the subsidiaries of Cigna, the Cigna Group, to see if they make more money when healthcare costs go up or if they make more money when healthcare costs go down. Okay, Cigna Healthcare makes more money when healthcare costs go down. Allegiance makes more money when healthcare costs go down. Express Scripts, as a PBM, makes more money when healthcare costs go up. Ascent Health Services makes more money when healthcare costs go up. Evercore is kind of similar to Interqual. Evercore makes more money when healthcare costs go down. MD Live, it's fee for service. They make more money when healthcare costs go up. VillageMD makes more money when healthcare costs go up. Again, it's fee for service. Summit Health, again, it's a massive fee for service physician practice. They make money when healthcare costs go up. So again, for the Cigna Group, you have a combination of up and down arrows. You even have up and down arrows within Evernorth. All right, so this is just the end of part 1. Stay tuned for part 2. All right, part 2 of health insurance company subsidiaries. Now we have CVS Health. Now CVS Health has a health insurance arm, and that is Aetna. And Aetna has one of these TPA subsidiaries as well, which is Meritain, which is analogous to UMR and Allegiance from United and Cigna. Next, you have CVS Caremark, which is the massive PBM within CVS Health. In fact, CVS Caremark is the PBM itself is actually the largest part of CVS Health. And again, it too has a subsidiary called Zinc, which again is a group purchasing organization, which is analogous to the GPOs that the other PBMs have as well, again, as a mechanism for collecting payments from pharmaceutical companies. Next, then you also have CVS Specialty Pharmacy. Again, if you're using CVS Caremark as your PBM and you need a specialty medication, then again, you can't just like walk into any random pharmacy to get that filled. You got to get a mail order through the CVS Specialty Pharmacy or through one of the CVS retail locations, which then brings me to the CVS pharmacy locations. Of course, all of the retail pharmacies that so many of us are familiar with. And then interestingly, a newer subsidiary is Cordavis. What in the world is Cordavis? Cordavis is actually a pharmaceutical manufacturer. That's right. CVS Health is actually starting to make its own medications. But in fact, they're not actually making anything. Cordavis doesn't have any like manufacturing plants. They just license it from other pharmaceutical companies that they contract with to make it. So essentially, Cordavis is just a pharmaceutical company like Shell Company. They don't actually have any manufacturing facilities. Okay, next up, we're moving on to Elevance Health, which is the largest Blue Cross plan in America. And Elevance has Anthem, which many of you are familiar with, and then they also have WellPoint, and both of them are the health insurance arms. Anthem, of course, does commercial insurance, and then WellPoint does a bunch of Medicare Advantage plans and Medicaid, and they also have ACA plans. And then there's also Carelon within Elevance as well. And Carelon is analogous to like Optum within United, where it's sort of the healthcare services arm of Elevance. And they have AIM Specialty Health. And what is AIM Specialty Health? Well, it's just like Evercore. So when most Blue Cross plans need prior authorization, they don't use Evercore, they use AIM Specialty Health, which does kind of the same thing that Evercore does. And then Carelon actually owns physician practices as well. It owns this physician group called Millennium Physician Group in Florida, which is a huge physician group. It's like one of the largest, if not the largest physician group in Florida. And it's actually a joint venture with a private equity firm called CD&R. Again, let's go through the up and down arrows for CVS Health and Elevance. Okay, again, where does this subsidiary of these two companies, does it make money when healthcare costs service? So Millennium Physician Group, they make money when healthcare costs go up. So why? Why do United, the Cigna Group, CVS Health, and Elevance have all of these subsidiaries? So there's a variety of reasons. So one is to give the appearance of choice and competition. This is a strategy that's used by the hotel industry. Shoot, Marriott owns all the Westins. And then there's W Hotels. And then you've got like Marriott Courtyard. And then you've got all these other things. So you think you've got all these choices. You don't think they coordinate those prices for all those hotel rooms? Of course they coordinate all those prices for all those hotel rooms because they're all owned by the same company. So you as a consumer, you think you have a choice in all of these hotels when you really don't. And so as an employer or as an individual patient or as a state government or even as the federal government, you think you have all these choices of all these different healthcare companies. And the point is you don't, because they're all subsidiaries of essentially four. All right, what's another reason? Is because these companies grew, especially over the last 10 to 15 years, by acquisitions. So many of these subsidiaries were an acquisition. United acquired Change Healthcare, and United acquired Interqual, and United acquired the advisory board company, and CVS acquired Caremark, and Cigna acquired Express Scripts, and Elevance Anthem acquired WellPoint. Okay, so why is that important? It's important because these companies and the concentration of health insurance companies in America grew because of industry consolidation through acquisition. And that acquisition was really financed through ultra low interest rates. In other words, cheap debt after the great financial crisis of 2008, 2009. So these companies became huge behemoths, even larger than they were before because of cheap debt and using that cheap debt to make acquisitions. Well, why does that matter? These companies didn't grow because they were better or faster or cheaper. These companies didn't grow by outcompeting. They grew by acquisition and cheap debt. So it's not like we're getting better, faster, cheaper service as a result of this consolidation. We're just the best horses won. The best horses didn't win. The hungriest horses won. The hungriest horses with the most ability to raise debt won. So that is why we have so many subsidiaries, and that is why I wanted to let you know what these subsidiaries are. And thank you for watching A Healthcare Z.
Okay, so that's Dr. Eric Bricker, who's a really fine educator about health policy issues. And I have one more tape from him discussing these same large insurance companies. So let's go to that.
Hello, this is Dr. Eric Bricker, and thank you for watching A Healthcare Z. Today's topic is intercompany eliminations. The secret to insurance carrier profits. That's right. Today I'm going to go over some accounting. So, of course, because we talk about healthcare finance here on A Healthcare Z, we have to talk about accounting, but this is super important. So, it involves numbers. Please pay attention. So, intercompany eliminations is where revenue from a subsidiary of one company cannot be counted as revenue again when another subsidiary of the same company does the services for subsidiary A. In other words, subsidiary A sold to subsidiary B. So subsidiary A is the customer of subsidiary B. In other words, you can't sell to yourself and count it and count the revenue twice. So let's use a specific example involving United Health Group because they do it as do the other health insurance companies. So in the case of United Health Group, they've got United Health Care, the insurance company, and then they have Optum, which is the healthcare services, quote unquote, arm of United Health Group. Now, let's say there was no intercompany elimination. So let's just say you're talking about United Healthcare, the health insurance company, and let's say they get $10,000 of premium for one particular individual. So then, per the medical loss ratio, they need to spend $8,500 out in medical care for that individual, which would then leave $1,500 remaining in non-medical care that United Healthcare can retain. And let's say they had $1,000 of expenses for paying their salespeople and commissions and adjudication and blah, blah, blah. So then you would take the $1,500 minus the $1,000, so that would leave you a final profit of $500 off the $10,000 of revenue of premium, and you didn't break the medical loss ratio because you were still spending $8,500 on medical care for that premium. Okay, fine. However, this is what United Health Group actually does. So, in the case of an intercompany elimination, again, let's say United Healthcare is getting $10,000 of premium for an individual, and they're spending $8,500 in medical care. But hypothetically, let's say that $8,500 for doctor's visits and going to see the having an imaging done or having a procedure at an ASC or having home health care or even their specialty pharmacy services and the PBM. So all that money is spent out, but that $8,500 isn't going to random hospitals and Dr. Joe and Dr. Smith. They're going all to Optum, right? Because remember that Optum employs thousands of physicians. They run the entire Kelsey-Seybold healthcare system in Houston that has hospitals and ambulatory surgery centers and all sorts of stuff. Okay, so let's just say hypothetically that all of that $8,500 goes to Optum for the medical care. Now, the intercompany elimination is, well, you can't count the $10,000 of revenue of premium to UHC plus another $8,500 of revenue for Optum. You can't count $18,500 in revenue because you'd be essentially double counting the revenue. So that's why you have to do an intercompany elimination. However, let's see what Optum then can do with that $8,500 in medical care. So let's say to actually deliver care for that individual, it only costs $6,500 of expenses. That means that they have $2,000 of profit off the $8,500. Now, the medical loss ratio only applies to UHC. The medical loss ratio does not apply to Optum. So, in this case, the $2,000 of profit can be added to the $500 of profit for UHC, and now you have $2,500 of profit off of $10,000 of premium. So, in other words, it is in more than the medical loss ratio. So, United Health Group and intercompany eliminations have completely gone around the medical loss ratio by being vertically integrated. And it's totally legal, and all the other carriers do it as well. So the Cigna Group does it. They in 2023, they created the quote unquote Cigna Group. It's not even called Cigna Healthcare anymore. It's the Cigna Group. Why? Because the Cigna Group is following the same game plan as the United Health Group. They've got Cigna Healthcare, which is the health insurance company, and then they've got Evernorth, which is the healthcare services arm, where they can do the intercompany eliminations. Next, we have Elevance. That used to be Anthem. Guess what? They still have Anthem. That's the health insurance company. And then the healthcare services side of it is called Carelon, which they can then do intercompany eliminations with. And then CVS Health also has Aetna, which is the health insurance company. And then they have the other subsidiaries like CVS Caremark and their CVS pharmacies, and their Minute Clinics, which are actually providers. And again, they can do the intercompany eliminations there as well. So what this means is that the health insurance companies are highly incentivized to, if I'm a shareholder of a health insurance company, I want the expenses for the provision of care to go down as much as possible. But I want the amount of payment from the health insurance side over to the healthcare services side. In other words, it's $8,500 here. I want that to be as high as possible. So, given that this is not going to change, okay? Is this right? Is this wrong? Like, I'm not here to debate that, okay? Actually, my point is that hospitals better get in on this. As a hospital, you better start, frankly, copying this, because if you don't, United Health Group and Cigna and Elevance and CVS are going to eat they're already eating your lunch, and they're going to eat your lunch even more. So that's my point for the day. Thank you for watching A Healthcare Scene.
All right. Well, thank you all for your attention. Sorry this whole thing was so long, but I hope you learned a lot. And we will meet again very soon. So thank you so much.